Hello, good evening, everyone. Ladies and gentlemen, friends and colleagues from near and far, my name is Dr. Helena Lim, Director and Fertility Consultant of KL Fertility Center, Monash IVF, Malaysia. It is my privilege to be invited as the chairperson of tonight's webinar entitled Optimization Without Compromise from OPU to Embryo Transfer. Before I go further, let me first and foremost introduce our esteemed speaker of tonight, Dr. Steve Levett. Dr. Steve Levett is the Director of Clinical Application, CooperSurgical, and he had an illustrious career in human reproductive science. After his PhD in molecular immunology in 1989, Dr. Levett obtained a position as a postdoctorate fellow at York University. He then took up his first embryology role in the early 1990s at St. James University Hospital in Leeds, United Kingdom. He then became a lab manager soon after and went on to manage different labs in the UK and Canada in the public and private sector. From 2006 to 2014, Dr. Levett worked for Wallace, then a part of Smith Medical, and become Global Business Director in 2010. He then joined Ferrings in 2014 as a UK National Business Manager for Obstetrics and Fertility, and 18 months later joined Live Global as a Vice President International Sales. Dr. Levett has a very keen interest in lab optimization, QC procedures, optimization of result, and supporting embryologists. His research interests have been in fertility preservation since working with Prof. Roger Gosden in Leeds. Currently, Dr. Levett is a Director of Clinical Application at CooperSurgical Fertility and Genomic Solution. Now, before we went on to having the full lecture, I'm sure which will be so interesting, let me do a few advertisements of our upcoming events. So our next upcoming webinar will be on the 27th of June, 2024 at 8 p.m. And the speaker will be Mr. Stephen Yap, the Senior Geneticist of Alpha Fertility and Women Specialist Center. Now, he's going to talk about salvaging euploid blastocysts from abnormal fertilization zygote in IVF through biparental testing employee assessment. Now, we also will be having our MSART meeting 2024 on the 5th to October 2024. And this is already open for registration. So I'm encouraging everybody to join us on this special event. Now, before I even run through, let me just go through the agenda of today's event. So we are going to actually have a lecture from Dr. Levett, and then followed by a Q&A session. If you have any question at all along the lecture, please submit your Q&A in the Q&A box. We'll address them during the Q&A session at the end of the webinar. So please do not feel shy. If you feel very shy to ask any questions, you can also privately message us. That's not an issue as well. So without further ado, let me get Dr. Levett onto the podium, virtual podium, to start his interesting lecture tonight. Dr. Levett, you're on mute.
Thank you. Let me unmute myself so you can hear. Thank you so much for that wonderful introduction. And thank you to MSART, to LabIVF and CooperSurgical for inviting me to give this talk this evening. Thank you also to everybody that's tuned in. I know it's late in the evening over there in Malaysia, so I do appreciate you giving up your time to listen to this talk. When I was asked to give a lecture and the title came up as Optimization Without Compromise, it's something close to my heart, but from egg collection through to embryo transfer, it's a huge topic. And obviously we can't cover everything in the next hour. So I've tried to pick out some highlights that I hope you will find interesting. Hopefully some educational content there as well. And of course, at the end, we're happy to take any questions that you have. So let's start. I'll just make sure I can move the slides on. So to ensure that we provide the best quality service to our patients, it's important that we have quality management, quality control in place, that we have standard operating procedures, and of course we need to understand whether we're doing a good job. Most labs that you visit, or most clinics that you visit around the world, when you ask, are you doing well? Everybody says yes. Everything's great. We're doing wonderfully well. But we need to ensure that we're doing as well as we possibly can, and we don't rest on our laurels, and we always strive to improve. So the first part of the talk is going to talk a little bit more about the quality management side, how we monitor our results, etc. Then we'll talk about optimization of the embryo culture system. And of course, we cannot forget that one of the key factors for success in the whole process is embryo transfer. We can produce the most beautiful eggs from our stimulation regimes. We can produce the most beautiful embryos in the laboratory. But if we can't do effective embryo transfer, then our chances of success are going to be somewhat limited. So what is quality management? Quality management is a discipline that we should all have as part of our everyday routine. And it's ensuring that the outputs, the results for our patients, and the processes with which we deliver that success, hopefully, meet all of the requirements of the patients and are truly fit for purpose. And quality management in its basic form has 4 components: planning, quality assurance, quality control, and continual improvement. And that is the cornerstone of our success and continuing success, and also our ability to adopt new techniques as they come, to assess them, and again, to constantly look to improve the outcome for the patients. I'm sure many of you have probably seen this sort of chart before, but it goes to the heart of the mindset that we should have within our clinic. And I've been very lucky to travel all over the world to different IVF centres, talk to clinicians, to embryologists, to nurses. And one thing that we're always very afraid of is change. When things are working well, we're very reluctant to change things. We're not sure how the results will work out and whether anything will be compromised. So, of course, if we're going to change anything, we have to have a very clear plan of how we're going to do it. But our mindset, as I mentioned, should be that we're continually looking for change and improvement. So this circle of quality management is always, or should always be, at the front of our mindset. So we identify opportunities for change. This might be through attending a conference, reading a published paper, talking to somebody from industry, for example, and we identify that opportunity. We test the impact of implementing that change. We check what's happening, we analyze the results, and then we act. And of course, if it's positive, we implement it fully. If it's negative, we start the cycle again. So I'm not advocating that we change all of the time, but we should always be thinking about how we potentially can change any aspect of the work that we do to try to improve the outcomes. And of course, that it does include quality control, and we're going to talk a lot about quality control today. And so we need to have methodologies to inspect and test what we're doing, measure accurately many different factors within the clinic and the lab. And of course, by doing that, it verifies that we're delivering what we should. We conform to all of the specifications, And as mentioned before, we're meeting our patients' expectations so that we deliver the best service for them. And quality control activities determine whether we meet acceptable criteria. And if not, why not, and what we can do to put them right. So quality management, quality assurance, quality control are a significant part of our thinking and should be part of our work. And of course, if we want to be accredited or have certification in our clinic, then these are a cornerstone of that particular activity, and they will be expected to be in place if you want to gain that sort of accreditation. For example, ISO, which some labs do have around the world. So we can look at some of the guidelines from the professional bodies. I've picked out ESHRE here. I live and work in the UK, so I've picked up from the ESHRE guidelines. And of course, you can go to their website. You can look at their publications to see what they believe should be at the heart of what we do in the embryology lab and in the IVF clinic as a whole. So, of course, there are some that are fairly obvious and some that we need to think about more carefully. So defining responsibilities and ensuring everybody is suitably trained and incompetent in what they do, of course, is important. And that comes down to every aspect of the work, including witnessing. So if we don't do electronic witnessing and we do manual witnessing, we should still ensure the competency of the person that's doing that witnessing. They should understand what they're looking at, and they should understand whether things are being done correctly. We also need to have validated written instructions for each process. We're going to talk about standard operating procedures. Most of the time when you talk to embryologists about standard operating procedures, they roll their eyes and think that it's an exercise that you do when you start a lab. You put them in a file, you file them away, and you never look at them again. But of course, that's not the case. They should be an active live document that we use constantly within our work to ensure that we're following the correct protocols. And you can see some of the other factors here that we need to ensure are in place. So full traceability, witnessing, etc. And we should audit that to make sure we're doing it correctly. All of the consumables, the equipment that we use are all suitable for purpose. We should never cut corners in using material that's not specifically designed for embryology and for IVF. And we should have a system to identify both errors and, more crucially, near misses. We learn more from near misses to avoid an error, a serious error. So we need to have a system in place to identify those and how we put corrective actions into place as well. So we should always have performance reviews to ensure that we're continually and systematically improving our quality management system. And a risk assessment is important for all lab activities. They don't need to be done all of the time. But if we're introducing some new protocol, then we should always have a look at the risk assessment to make sure that we've thought about all of the potential pitfalls, some of the potential problems there might be in introducing something new into the clinic. Competencies are important, and many times when I travel with trainee embryologists, we're asked how many procedures should an embryologist do to ensure their competency. And again, ESHRE have a certification for embryology, and these are the numbers that they recommend. Now, everybody's different. Everybody takes a little bit of variability in learning certain things, and some are quicker than others. For example, it says to do 50 egg retrievals. Well, most embryologists will pick up the procedure much quicker than that, whereas ICSID also says 50, and some embryologists may take a lot longer than that to acquire full competence in that particular procedure. And we know that it is very variable depending on the operator as well. So we should have a plan to determine whether our staff are competent in what they do, whether we've got the training regime in place that will allow them to achieve competence, and that they maintain that competence over time. It's okay learning a technique, proving that you can do it correctly. But if you then don't do it for a number of months, years, whatever it might be, if we go on maternity leave, for example, then again, when you come back, you need to ensure that you've maintained that competency. There's a very nice paper that discusses embryo transfer from a clinical point of view, and it purports to say that if you do an embryo transfer fewer than every 10 days, then your competency starts to decrease. So it can happen fairly quickly depending on what that procedure is. So we should always maintain competency within our units, not only in the embryology lab, but the clinical team, nursing team, etc. This is always an issue around the world, that staffing levels generally don't meet the workload that we find in different labs. And both ESHRE and the ASRM have some guidelines to help us understand the staffing levels we should have. Now, again, it says from up to 150 retrievals, we need at least 2 qualified people. We should have 2 people in the lab, regardless of the number of cycles that there are. And then for every 150 cycles after that, we add 1 more person. And that ensures that all of the workload is covered effectively. We don't suffer from fatigue, from stress within the lab, and we can deliver the service that our patients expect from us. So it depends on your setup, on your particular clinic, but in general terms, those are the numbers. The ASRM ones vary a little bit, but are in a similar sort of range to determine the numbers of qualified staff that we should have. And of course, if you then have a clinic that has trainees where people need to take time to train others, then you need to assess that you have enough cover to allow that to happen. So, as I mentioned, standard operating procedures are crucial, and they are a document that should be active and live, and that we refer to, particularly if we're training new staff. And the standard operating procedure should cover a number of things: who will perform the task, what materials are needed, why the task is being performed, when and where, and how the person or any appropriately trained person will execute the task. So it covers a wide range of topics to ensure that everybody is doing the same thing within the lab. It seems a trivial point, and when things are going well, you may not think it's important. But if anything happens within the clinic, both clinical practice or embryology, if something goes wrong and everybody is doing something different, it becomes extremely difficult to pinpoint where the problem is and to put corrective action into place. So we should always try to follow standard operating procedures, and they should be written carefully to reflect the true nature of that particular task. And why do you need it? To ensure safety, to ensure everything goes according to the schedule, to prevent failures in the process, and of course to be used as a training document. And you can see on the right here in the blue, it ensures standardization and compliance with any standards or regulations that there may be in any particular country or region. Hopefully it maximizes production requirements, and it to ensure that the procedure itself has no adverse impact. And they are appropriate for everyone within the clinic. People always focus on the lab and on the embryologists, but standard operating procedures really ought to be in place for all of the members of staff within the clinic to ensure that everybody knows what they should be doing and everybody is doing the job effectively. So I'm going to talk about quality control and KPIs and how we monitor them. And I just wanted to share this particular slide because this shows the power of collecting data, analyzing it effectively, and ultimately how it can change, in this case, change the world. So this is a paper that was published by Hubert Joris a little while ago now, and it demonstrates the early days of ICSI. And so the guys in Belgium, in Brussels, looked at their KPIs and tried to analyze what was happening. And in the early days, ICSI itself was not really very efficient. and they realized that they could probably do something to improve the technique. So if you look at the graph, you'll see the darker blue line at the top shows percent intact oocytes after the micromanipulation. Now, the people in Brussels were very skilled micromanipulators because they'd been doing other techniques before ICSI came along, most notably subzonal insemination. So their damage rate was very good from the very beginning. But in green, you can see the normal fertilization rate started off in the mid-30s percentage, and their 1PN rate was significantly higher than you would expect, so peaking at around 20%. Now, if it had remained in that area, would ICSI have taken off, and would we be universally applying it to the clinical setting? Probably not. So they identified some things that they could change, and when they made those changes, they looked at the KPIs, they plotted them in this control chart, and they saw significant benefits from those changes. So in the green, you can see after the first quarter of 1992 that the normal fertilization rate started to increase quite significantly. And at the same time, the 1PN rate dropped down and then became low, as we would expect from our practice today. So what did they do to achieve that goal? Well, the next paper explains what happens in those early days of ICSI. And I think a lot of embryologists are unaware that in those early days, they did not immobilize the sperm for ICSI. They were doing subzonal insemination with motile sperm, where you pick 4 or 5 motile sperm, you put them in the perivitelline space. They realized if they were going to do an injection into the cytoplasm, that they needed to select 1 sperm. But initially, they didn't immobilize it. And of course, they didn't then aspirate the cytoplasm. So they got a relatively low fertilization rate, normal fertilization rate. When they introduced immobilization of the sperm, the fertilization rate went up. And then when they introduced the aspiration of the cytoplasm, they saw quite a leap in normal fertilization, even without immobilization. And of course, when they introduced the 2, which we, of course, all do today, and it seems common sense that that's what we should have done from the start. But when you're introducing a new technique like this, it's a huge learning curve. So when they aspirated the cytoplasm, immobilized the sperm, they got to a fertilization rate that we expect to see today. So monitoring key performance indicators, looking at this data very carefully, can help us really improve the outcomes in our clinic. So where do we get the information from? Well, there's a number of sources, as I'm sure you all know. The Vienna Consensus that was published in 2017 talks about general laboratory key performance indicators and performance indicators. And the Alpha Consensus published earlier, this is a revised version in 2017, earlier in 2012, looks at cryopreservation. And this looks at the difference between slow freezing and vitrification. And these are really good publications to have a look at, to get some background information to help you in your lab and your clinic understand where you should be, perhaps where you can aim for, but also you might find that you are doing significantly better than the consensus from this panel of experts. And of course, you adjust your KPIs accordingly. There is now a consensus for clinical work. This is the Maribor consensus published in 2021 by this expert panel that you can see. So now we have both embryology and some clinical performance indicators to work with. The clinical ones are slightly limited, and you can see here cycle cancellation rate, cycles with moderate to severe OHSS, etc. They don't go into a great detail in the performance indicators that are mentioned, but it's a start to help us try to understand where we sit compared to everyone else within the world of ART. Okay, so we have performance indicators, reference indicators, performance indicators, and key performance indicators. The reference indicators are mainly revolve around the quality of the eggs coming into the lab. Performance indicators are the data that we collect, but we don't necessarily routinely put in a control chart to see how things are going. And of course, the key to our work, key performance indicators. And within each of those categories, the expert panel, the consensus, came up with a competency value and an aspirational goal called the benchmark. And as you'll see from just a couple of examples, those are recorded, and they may or may not reflect what's happening in your lab. And of course, you must adapt them accordingly. So if we look at the reference indicators, these are important feedback tools for the lab to feed back to the clinical team, because the key starting material that we work with, of course, is extremely important. So good quality eggs is going to help us produce good quality embryos and the best chance of success. So there are only two recorded: the proportion of eggs recovered, so the number of eggs times 100 over the number of follicles recorded on the day of trigger, and the number of M2 mature eggs at the time of ICSI. Now, the top one proves a little bit problematic because that relies on our clinical colleagues measuring all of the follicles and recording them. And many, many times when we come to look at making dishes, we look at the folliculogram, we see the number of follicles, and then we end up with more eggs than follicles. So, of course, that number then becomes slightly nonsensical. So we need to work together, but also the number of mature eggs is important. We also need to feed back the quality of the eggs, whether we have darkened cytoplasm, whether the zona pellucida looks normal, whether there's large perivitelline space. All this information can feed back to the clinical team and help them understand what's happening, and hopefully improve the quality of the eggs coming into the lab if necessary. Then there's a number of performance indicators. You can see them listed here. I'm not going to go through them all in detail, but it's interesting, to me at least, that the committee of experts and the consensus looked and said that good blastocyst development rate was a performance indicator and not a key performance indicator. And I would argue within the lab that that is one of your key performance indicators, along with the utilization rate. So again, there's a competency value and a benchmark value. So good quality blastocyst, we should be getting at least 30% and hopefully 40% or more. If you're already above this, then of course you don't set your competency and benchmark values at this level, you set them higher. If it's lower than this, and this is a strive, then again, you set them a little bit lower to start with to try to improve gradually. Because if you don't meet your performance indicators and key performance indicators, you have to report why and what you're going to do to improve and reach those standards. So here are the key performance indicators. ICSI damage rate, as you might imagine. Now here, the competency value is less than or equal to 10%. So for most experienced embryologists, they would expect to get a much lower damage rate than that. And you can see some of the others listed here. This is the first slide that shows one of the key points when you're looking at KPIs in your lab, and that is that you must use a reference group if you want to compare timeframes or people, whatever it might be. If you want to compare one thing to another, we need to rule out patient variability. So here there's an example, less than 40 years old. Some may choose to do less than this, so do under 38, for example, that have really got a normal hormonal profile using their own eggs and ejaculated sperm without genetic testing. Again, if a lab does a lot of genetic testing, then that might be problematic, but we really need to ensure that we're using this relatively good patient prognosis group so that we can compare like with like, so we don't, as I mentioned, bring in patient variability into the system. And for me, one of the key for embryologists is using this day 5 blastocyst utilization rate. I think this is one of the key factors to determine whether your lab is producing good quality embryos on a consistent basis. Okay, so quality management system helps us achieve the best outcomes. We must document all processes using SOPs. Within the SOP, if we're looking at auditing, we have to encourage the staff to have both positive and negative feedback so that we can continually improve. And this robust quality system helps us improve outcomes for the patients. We should evaluate the process and review our SOPs on a regular basis. And of course, if we make any changes, we need to introduce a new SOP. And KPIs are there to help us measure performance and see whether things are stable or whether we have a potential problem, and they help us identify things relatively quickly. If we wait for pregnancy rates, clinical or otherwise, then we're going to have a big delay in getting that result. And in the meantime, many patients could be affected. So KPIs earlier in the system are going to be beneficial. Okay, so we're going to move now to the lab and look at optimization, look at egg collection, dish preparation, and then after that, we're going to talk about embryo transfer. So the whole idea of our embryo culture system is that we're going to minimize insults and stresses to the gametes and the embryos. That's fundamental to what we do. Sounds easy, but of course it's not, and it's actually quite a significant task within the embryology lab. And we have to remember that we can't just improve one thing or monitor one thing within the lab. We have to ensure that everything is optimized. This paper was published a few years ago now by Don Rieger that I used to work with at Life Global, and he identified 175 factors within the lab that can influence outcome. Now, whether that's a true number, whether it's slightly below or slightly above is not the point. It's a complex system of procedures that interact with each other. They complement each other, they're synergistic, and if we don't get them all optimized, we're not going to achieve the best results. You can see here, culture media is often the focus of quality control and an optimization, but we need to make sure everything else is appropriate as well. So temperature is a very interesting factor and one that we should not overlook. When I travel to embryology labs around the world, often notice that their heated stages, their workstations are turned up above 37 degrees because I think there's a realization that if you set your work surfaces at 37, it's not always possible that the drops themselves are going to reach 37 degrees. And that is the crucial factor. It doesn't matter to an extent what our work surfaces are set at. The crucial factor is that the temperature in the culture drops is maintained at or around 37 degrees and remains stable. So we don't just do one-off measurements to determine what's happening. We need to ensure that they remain stable over the time frame that we're talking about. This is particularly important if we're looking at denudation, looking at ICSI, where we're going to work outside of the incubator, potentially with MOPS or HEPES buffered media that rely on temperature to maintain a stable pH. The choice of dishes can have an impact. And of course, we all know when there's been a lot of focus over the last few years on oil, to ensure that we're using the correct oil and the right amount of oil to minimize any changes that we see over the time we've got embryos in culture. So factors that can influence the cumulocyte-oocyte complexes, so basically the egg quality. I've just mentioned temperature. We know pH can have an impact, and we should maintain it carefully within this range at all times. Osmolality is also a factor. So if we see any evaporation, we're going to see an increase in osmolality. We're going to talk about that a little bit later. And of course, sterility and cleanliness go without saying that we need to maintain that throughout. When we're looking at temperature, why is temperature important? Well, temperature changes, particularly drops in temperature, can have a significant impact on the spindle within the oocyte. And when the spindle is rearranged and disorganized, there's often a chance that it will not return back to normal. So it's critical that we maintain good temperature control throughout the egg collection process. And is that usually the case? Well, we know that it's not, but it's not often in the area that people expect. So this is a study done a few years ago now, almost 20 years ago, looking at the temperature change during egg collection. So we measure the temperature at the tip of the needle, at the hub, in the tubing, and also within the tube itself. And as you can see there at the start, we're more or less at 37. There's a drop along the needle. There's a smaller drop along the tubing. At the bung, again, slight drop, but then there's a big drop when the follicular fluid drops from the tubing into the bottom of the tube. So this is where we need to take care. This is where we need to make sure that the tubes are warmed properly. They're kept in a tube warmer throughout the process. Your hand is not 37 degrees and will not maintain 37 degrees. So that tube should stay as long as possible in the tube warmer. And one way to avoid some of the loss is to preload the tubes with some warmed media before the aspirates go in. So egg collection can have a significant effect on temperature and therefore potentially on the quality of the eggs that we're working with subsequently to create good embryos. So where is the temperature lost? Well, as you can see, around 80% of the temperature is lost during internal heat losses, so along the tubing, etc. 15% is lost through the walls of the tube, particularly if the tubes are not pre-warmed. And then there's a loss to the environment, which is very difficult to maintain because we can't work in 37 degrees in the operating room or in the lab. So loss of temperature at the entry to the collection tube appears to be the most significant, and that's where we need to take care. And also along the way, we need to validate the heating blocks that we use, any transport devices, the heated stage that we're working in, the dishes and the incubator. So temperature mapping within the lab is crucial to maintaining good quality and optimized culture conditions. We often look at pH, we often look at osmolality, but if we can't control temperature effectively, then we're going to have problems. And remember, it's the temperatures in the drops, what the embryos are and the gametes are actually going to see, that's the crucial factor. So just measuring the temperature on your heated stages or on your workstation is not enough to really understand what's going on and how long temperature remains stable. And that was published a few years ago by the guys at Embryo Tools in 2015. And you can see that in this example, the choice of culture dish can have an impact on temperature control. So if we put the dishes on a 37-degree heated stage and we measure the temperature in the drops, what they found was using a conventional Petri dish with this air barrier underneath, which is also, they have these shoulders on the bottom of the dishes because originally Petri dishes were designed for microbiology. So they need to be raised slightly so you don't scratch the bottom when you move them. But also in the incubator, they're stacked one on top of the other. So they need that gap underneath. But that air barrier acts as an insulator. So it means that if your heated stage is at 37 degrees, in the example on the left, it's unlikely that the drop in the dish is going to reach 37 degrees. Whereas if you use a dish designed for embryology, designed for embryo culture, there's much closer contact between the bottom of the dish and the heated surface. And in this scenario, you can achieve 37 without raising the temperature of the heated surface. If you read the paper, it's quite interesting because on the left, in this scenario, or if we turn that up to 38 degrees to get 37 in our drops, for example, they found that over time, that temperature drops again because of exposure to the environment. And they were finding that they only had about 3 minutes to work with that dish before the temperature drop was unacceptable and may cause damage. So think about that when you're thinking about working with dishes outside of the incubator. We never have as long as we think we do to work, and we should be using our protocols to take that into account. So don't put too many human site oocyte complexes into the dish for denudation, for example. Don't put too many eggs in your ICSI dish because it will not maintain temperature and therefore pH over the time frame that you want. So we're going to talk about culture dishes, and again, it seems such a simple process within the whole IVF world, but it can have a huge implication on our outcomes and on the stability and optimization of our culture system. This is a nice quote from Stephen Keeg here: proper preparation prevents poor performance. And that is particularly true when we talk about dish preparation. So what are we looking for when we're making dishes, and what are the pitfalls? Of course, we want to avoid contamination. Thankfully, nowadays, we don't see so much bacterial or fungal contamination as we did in the very early days of embryology. But we need to be aware of the role of volatile organic compounds, both in the lab atmosphere and in the plasticware and other consumables that we use. We need to establish and control the culture conditions for osmolality, for pH. We need to equilibrate dishes correctly, and we need to manage the bottles of media and oil that we use so that we don't keep them exposed to the environment for too long. And of course, we need to look at the integrity of the microdrops. The well dishes help, and we'll talk about that in a little while. How the dishes are treated. This is interesting because a number of labs around the world use the lids of culture dishes to do ICSI, for example. And the companies that make the dishes don't prepare the lids in the same way because, of course, they don't expect anything to come into contact with the lid. So again, be careful that you're using the appropriate materials for the practical purpose that you want them for. So off-gassing is important. We know that most plasticware is going to have at least some VOCs. We need to monitor them. We need to use a suitable VOC meter, and that's one that measures down to parts per billion. That's the range we're talking about in an embryology lab. Some of the older VOC meters measure down to parts per million, and if you're getting a reading on that, your VOCs are definitely too high. So off-gassing of all the plasticware is important. If we're going to introduce new equipment, particularly incubators, into the lab, they also need to be off-gassed and burnt in so that they don't release those VOCs into the atmosphere. The other factor here is if we use VOC filters, we need to ensure that they're changed correctly and on time, because if not, once they become saturated, then they become problematic and may cause you some issues going forward. So off-gassing, control of VOCs in the lab is critical. It can have impacts on some of the embryology parameters that we measure. Some of the papers have shown that, but it can also impact miscarriage rates. So VOCs may not manifest themselves and their effect in the embryology lab, but they may manifest themselves later on in the ongoing pregnancies. So VOCs are important and we need to minimize them as much as possible. Now, one of the topics I've talked about a lot over the years, and certainly when I was working with Life Global, spent a lot of time helping labs understand the pH of their culture media, how it remains stable, how to modulate it, etc. And pH is important throughout culture, but it's specifically crucial at certain times. And you can see here, denuded eggs cannot regulate their internal pH, so they rely absolutely on the external environment. So when we're stripping eggs for ICSI with the hyaluronidase, when we're doing ICSI itself, the maintenance of pH at that time is crucial. You can see here some of the effects it might have on mitochondria, on cytoskeletal factors. It can affect blastomere division. It can increase fragmentation rates, and it may then impact the overall morphology of your embryos and ultimately impact the outcome for the patients. The other time that pH becomes critical, and one that's often overlooked, is when we've warmed vitrified embryos. They lose the ability again to regulate their internal pH for a number of hours after they've been warmed. And so when we're looking at our protocols, when we're looking at what we're going to do post-warming, do we put them in embryo transfer media? Do we put them back into culture media? The key factor is wherever they go, that the pH is stable and suitable for the embryos at that time. If we incubate or equilibrate dishes for too long without oil covering, so expose the atmosphere, we'll get evaporation, we'll get an increase in pH, and that may be detrimental to the ultimate outcomes. So again, pH is important throughout culture, but there are specific times where you need to be even more careful in maintaining that stable pH environment. pH is a very well-known, well-understood equation. Basically, the companies that you buy your culture media from set the bicarbonate concentration. So to modulate pH, you adjust the CO2 concentration. And I apologize for the slide, there's some overlap here. So we don't know exactly what the optimal culture media pH is. We know that the internal pH of human embryos is around 7.1. So consequently, all companies more or less set their range between 7.2 and 7.4, because above 7.4, we know there can be problems. So the only way that pH can be changed if we don't allow evaporation is to change the CO2 concentration. So if we increase CO2, pH decreases, decrease CO2, pH rises. If you allow evaporation in your culture system, of course, it will in effect increase the bicarbonate concentration, and therefore again you'll have an impact on the pH. So if you're doing testing, we don't just test the dishes on day one, so we set them up on the day before egg collection, and we test them the day we would have put the gametes into them, or the injected oocytes. But we need to understand over the next few days in culture whether pH remains stable. And here's an example of how things might be affected. So these are obviously not culture dishes or culture wells. These are cells to do pH testing in. But if you look at the cells on the left, it's quite clear without magnification that there's a difference in the volume in the cells. So B is as it was set up, and A is after 7 days. And this, in this particular scenario, 35 microliters of oil was overlaid on each of the cells. And you can see over 7 days, there's evaporation, there's a significant decrease in the volume in cell A. On the right, the oil volume, or the oil overlay, has been increased to 50 microliters, that's all. And they've magnified this so that they can show you there's really very little difference, very little loss here. And if we look at the table above, and we look at the oil volume, 35 microliters and 50, the final pH is still pretty acceptable in an embryology term between 7.2, 7.29. But look at the change in osmolality. There's almost 100 milliosmol per kilogram change. And that is quite significant if we extrapolate that to the human embryo situation. So bear that in mind. A small increase in oil here had a profound protective effect on osmolality. And osmolality is our biggest enemy in culture, particularly now we want to do day 5, day 6, day 7 blastocyst culture. This paper by Jason Swain was published a few years ago, and it is based on a mouse model. And we know we can't always extrapolate from mouse to human. But if we take this as an example of what might happen, you can see on the different grade bars that the starting osmolality was about 270 milliosmoles. The end was about 330. And as time goes on, we see evaporation, we see osmolality rising, and it has a profound effect on mouse embryos to a point where at 330 milliosmoles, you don't see any blastocyst or hatching blastocyst formation. So osmolality is always going to rise in our dishes. However hard we try, we will see some increase over time. But our job as embryologists is to minimize that as much as we possibly can. And there are strategies that we can use to do that. So this is a little bit abstract. It's on a mouse model, small drops. And then Jason went on to propose how we might make dishes to minimize the effect of evaporation and therefore osmolality changes. So in the same year, same paper, they published this bar chart showing some of the factors we need to take into account. So I think everybody would recognize that you're likely to see greater evaporation if the temperature is increased. So perfectly clear here that when the dishes were made at room temperature, we saw a smaller rise in osmolality than we did if we made it at 37. So remember, you're seeing a rise in osmolality as you make the dishes. So this is not a few days later, this is as they are made. So we're already introducing some stress into our system. Airflow made very little difference. And of course, we need to maintain sterility. So we should have airflow on. The drop type, they did two different methodologies for putting the drops in the dish. Normal is on the right here, the standard. And you can see that incurred slightly higher or significantly higher evaporation. The wash method is putting drops into the dish, overlaying with oil, taking those drops out, and then underlaying media underneath. So two-step system. And also, as you might expect, the drop volume can have a significant effect on your rate of evaporation and therefore change in osmolality. So there is a temptation to reduce the volume of media, of oil that we use, maybe to save costs, save money within the lab or within the clinic. But you need to understand where you introduce risk into the system. So as the drops get smaller, the surface area to volume ratio gets bigger, the risk of evaporation increases. And you can see here between 10 microliter drops and 20, 40, there's a significant difference in the evaporation and therefore the osmolality. So don't be tempted to use too smaller drops in your culture system. This will be detrimental. You're already seeing a 20 plus milliosmol per kilogram rise here. And that, of course, is going to get worse over time. So we may end up at a milliosmoles above 300, which is potentially going to be detrimental to embryo development. So in a more realistic environment here, you can see in the bar chart on the right in the grade area, the media volume was much higher, so 200 microliters, and the oil volume was in the dark blue, 8 milliliters, green 10, light blue 15. And you can see now with a large volume of media, oil can have a significant impact. So we should be using the maximum amount of oil that any dish that we use can contain without causing the lid to stick and without spillage. So that's the key factor. So the mantra for embryologists should be we use the maximum amount of oil in any dish, not the minimum. I have seen embryologists look at the side angle of a dish to check that the oil is just at the top of the drops. This will never remain stable in culture over the 5, 6, 7 days that we want. So rule of thumb, 2 to 3 millimeters of oil above the top of the drop will certainly be protective and will help you. So if you imagine that most commercially available culture media starts its life in culture at about 260, 270 milliosmoles per kilogram, if in that first example that you saw where there was 100 milliosmol per kilogram increase over that 7-day period, that's going to take it way into the range that's likely to affect embryo development. So please be cautious when you're making dishes that you use the correct and the most amount of oil that any dish will allow you to use. And again, the type of oil can be effective and can have different effects over time. So you can see as time goes on, the heavier oils, the more dense oils are more protective. So again, that's something to consider, particularly if your situation is extreme. So if you're using dry incubators, your lab is extremely dry, so the relative humidity in the lab is impacted. You want to use relatively small drops, then using a heavier oil, more viscous oil may help you in be more protective and controlling the environment. I would just point out that it also applies to time-lapse incubators. Most time-lapse incubators on the market are dry, and therefore they are susceptible to evaporation as well. So don't assume that using single-step media in a time-lapse incubator is going to maintain pH and osmolality over the time frame that your embryos are going to be in there. You need to test it, particularly pH, to ensure that it's stable over that time frame. If not, it may be beneficial to change the media at some point before day 5. And again, if you have embryos that are slower developing and you're going to keep them beyond day 5, I would always recommend changing the media on that day, because it's unlikely that that media will remain optimal for the next couple of days when you want to see whether you get blastocyst formation on day 6 or day 7. We need to ensure that everything is equilibrated properly, and in the early days we thought a couple of hours would be fine, but you can see here from the paper in 2008 we need a minimum of 10 hours to get our dishes into full equilibration. That also applies if you want to make dishes with pre-equilibrated oil, pre-equilibrated media. As soon as you put them into a new dish and you want to get them fully equilibrated, it still takes 4 to 5 hours. So much better to make more dishes the day before, equilibrate them overnight, than try to make them in an emergency. And it's not just the volume, it's also the shape and size and how you make the drops. You can see here, these all have the same volume. So if you make a nice rounded drop like this, you can see the surface area, 52 square millimeters. If we make an elongated, flatter drop, we've increased almost by 50% the surface area. And if we use dishes with preformed wells, we significantly reduce the surface area. So this is going to impact evaporation rates. This is going to impact whether your system remains stable over our culture period. So how you make the dishes, what dish types you use, make sure that the drops are the right volume, not too low, and you use the correct amount of oil. So we've got our system optimized, we've got great embryos. Now what? We need to do embryo transfer in an optimal way. So I think most would recognize this. Increased success rates within IVF have primarily been ascribed to improved stimulation protocols, so we get better eggs, and because of that, better lab techniques, we can produce better embryos. But outcome failures in IVF are often associated with embryos that look perfectly good at the time we do the transfer. We don't know why they don't implant, so we assume that something to do with the embryo is at fault, or something to do with the receptivity of the endometrium. But as I mentioned, most failures occur after the transfer of what appear to be apparently normal embryos, and much of the failure here can potentially be attributed to suboptimal embryo transfer technique. So as I mentioned, we can do the best we can to create good quality embryos, but if we cannot do an embryo transfer correctly, we're going to struggle to give the best service to our patients. The guidelines that are available are not really very helpful because they tend to give you some administrative advice, or the latest ESHRE guidelines that were revised really only look at the number of embryos we should be transferring. And ESHRE are very strict in Europe now. In most countries, the focus, of course, is on live birth and giving patients a healthy, normal baby, but also reducing multiple pregnancies. So for ESHRE, the guidelines mostly revolve around doing elective single embryo transfer. In their eyes, looking at all of the evidence, there's no reason to do more. And they also pick out certain conditions where it must be strictly adhered to. So here, it depends on the country whether you're allowed to use donor eggs or donor sperm, etc., but donor embryos. But if we're using gestational carriers, patients at risk of OHSS, and they recommend that if we're doing a fresh blastocyst transfer, we should absolutely stick to single embryo transfer to ensure that the patients have the best chance of having a healthy baby and reduce multiple pregnancy risk. So what do we consider from the clinical point of view? This is a list from the publication. It may not be fully comprehensive. This is what I could find that people look at. Much of it is common sense. If we do an atraumatic, a smooth embryo transfer, it's going to be the best outcome. Mucus removal has gone backwards and forwards from removing every drop of mucus to now the recommendation just removing the excess. Where do we put the catheter? Where do we deposit the embryos? We don't want to touch the fundus, so we want to avoid uterine contractions. How fast do we expel the embryo from the catheter? How quickly do we withdraw it? What do we do if there's retained embryos? Do the patients need bed rest after embryo transfer? Of course, training and experience of the people involved, embryology and clinician, is an important factor. Should the patient have a full bladder? Which sort of catheter should we use? And is ultrasound beneficial? And I'm just going to go through a few of these, of the more fundamental ones where there's clear evidence for one or the other. So atraumatic transfer, without question, is the best way forward. And you can see there's a number of papers that are published that suggest blood on the embryo transfer is a negative indicator of outcome. So the smoother, the easier we can make the embryo transfer, the better the outcome is going to be. Catheters, there's a huge choice on the market. I think in the early days, there was this choice between soft and stiff catheters. Really not a choice anymore. We should use a soft catheter. Do we use what is essentially the old type of a two-piece embryo transfer catheter, or the new ones that came onto the market with a bulb tip? They are essentially used differently. Do we just load the embryo and do the embryo transfer, or do we get the catheter into place first and then load? There are stylets, the size generally 18 to 23. There's not much variability there. Again, I was involved with Wallace, but I still don't know why we chose 18 and 23 centimeters, why we didn't choose 20 and 25. That information, that knowledge is lost in the mists of time. Do we use an echogenic versus a non-echogenic catheter? Of course, there's cost, there's packaging, supply, etc. And in an ideal world, everybody that does embryo transfer in the clinical team should use the same catheter. It makes life very difficult if everybody uses something different, because there is a learning curve between catheters that people need to follow. And if you mix them up and give them the wrong one, that might be detrimental. Again, in the early days, early 2000s, there was big debate about whether ultrasound was beneficial. Really, nowadays, there is no doubt. Everybody should be offered ultrasound guided transfers if it's possible, to give them the best chance of success. Where do we put the embryo? Obviously, ultrasound helps us. There's a fair bit of evidence that the embryo transfer catheter affects implantation and pregnancy rates. So there are some places that we should avoid: too close to the cervix, too close to the fundus. But beyond that, there's a little bit of evidence, fair evidence, that the placement of the catheter in the upper or middle part of the uterine cavity is going to be helpful, but greater than 1 centimeter from the fundus. And there is no more evidence that anywhere more specific than that. So we shouldn't spend a lot of time thinking I need to be 1.2, 1.3 centimeters from the fundus, because time is also important. From the lab, we need to have a clear plan. We need to stick to the SOP, and we need to consult with everybody so everybody knows what's going to happen, including the patients. So this is crucial, to have a plan, have it written, so we understand what's going on. Now, I'm often asked which is the best embryo transfer media. As I mentioned before, control of pH and osmolality is critical. So whichever you're using, you need to ensure that that's the case. Some people use culture media, so bicarbonate buffered media, that needs CO2 to maintain its pH. So if you're not working in a closed cell or one of these closed environments, then really the choice is between HEPEs and MOPs, or both. And there are, of course, now some specialized transfer media. Many people use them with hyaluronan. There's new ones coming onto the market that are going to contain a cytokine, GM-CSF, some evidence that that is going to be beneficial. But whatever it is, you need to ensure that it's optimized and it is equilibrated correctly. So we need to control for temperature, pH, and osmolality at all times. Loading techniques. Does it make any difference whether we load a full column of media, whether we use air bubbles, how many air bubbles, etc.? There's a lot of variability around the world. The truth of the matter is, and when you look at the published data, it makes no difference. There are factors that are important, but whether you use air bubbles, you don't use air bubbles, how many you use is not one of the factors that's important. Volume is important. So when we're loading the catheter, whether we use air bubbles or not, the volume of the medium that the embryo sits in is the critical factor. If you use too low a volume, you could have problems, and if you use too high a volume. So somewhere between around 30 microliters is going to be effective, which in a catheter looks like about 1 centimeter column of media. We should warm the catheter through flushing it with the medium. Warming it in an incubator is counterproductive. We shouldn't do that because the packaging contains glues and other things which will release VOCs. Flushing the catheter with warmed media containing protein is going to be quite sufficient. So make sure you flush it adequately, and that will help maintain the integrity of both the air bubbles and the media drop that the embryos are in. There's a number of studies that show timing is important. So quicker we get the embryo from the incubator into the patient, the better the outcome is likely to be. And there's a number of papers that show that. And of course, that then is also implicated if there's difficult transfers and what happens if it takes longer with environmental stress, i.e. change in temperature, pH, osmolality, etc. So there's a couple of studies that show that. There is one study that said there was no difference, but there are some caveats there. And if you read the paper, it might suggest that. But in essence, the speed that you get the embryo from the incubator into the patient, the better. We must check the catheter after transfer to see if there's retained embryos. We should have a very robust SOP in place that everybody understands, that kicks into place immediately should this happen. If it's followed, if it's done correctly, it has no detrimental effect on pregnancy outcomes. So as long as we know what we're doing, we're going to be okay. It's not something we want to see often, but if it happens and you act quickly, there should be no detrimental effect. So this paper that was published in 2021, this is where I'm more or less going to finish, said there's an urgent need for standardization in embryo transfer. Everybody does something slightly different, and they tried to highlight some of the things that are important and where there's evidence to suggest it. So we don't need to use anesthesia or analgesia. We should use sterile gloves. We don't need to use a warm speculum. Sterile water or normal saline for lubrication of the speculum. The cervix can be clean but not damaged by removing mucus. The ultrasound guidance is critical, and we should adopt it wherever we can. Abandon the transfer if you see fluid in the endometrial cavity. Perform a mock transfer in specific indications. So if there's a previous difficult transfer, or you know the patient's had surgery or some anatomy that's going to be difficult, the embryo should be placed in the upper or middle part of the endometrial cavity. Only, and I stress this, only use a stylet in the worst possible case. If you use it routinely, it's likely to lower your pregnancy rates. Avoid the use of a teneculum. Slow and steady pressure on the plunger. So we don't want to fire the embryos in, but we also don't want to be hesitant, and we should keep pressure on the plunger when we've inserted the embryos. If you let the pressure go, there is a small back pressure, and it could draw the embryo back towards the catheter. There's no need to leave the catheter in place for any length of time. Usually recommend it's rotated through 90 degrees, and the patient doesn't need to rest afterwards. They can leave immediately. So that's a brief summary of embryo transfer. It's a huge topic. We could spend many hours discussing the different embryo transfer techniques, but those are some of the critical points. So we need to do an atraumatic transfer using ultrasound, minimize the time, try to minimize as much as possible discomfort for the patient. Full traceability. We know there's been issues when embryos have been transferred to the wrong patient. And of course, we should transfer the best quality embryos. Appropriate media, consumables, equipment, control of conditions is vital. Temperature, osmolality, etc. And of course, timing with the endometrium, we know can have an impact. Just running over a little time, so quickly to summarize. Key considerations for embryo culture optimization: scrupulous with cleanliness, including air quality. Be aware of possible effects of reusing open bottles, etc. Test your plasticware and everything that you use to make sure it's suitable for purpose. Osmolality can change and will change over time, so how you set up your dishes is important. Make sure you don't set them up on a heated stage. Try that underlay technique if you have time and the resources. Larger drops are better. Rate of change is affected by that surface area to volume ratio. So dishes with preformed wells are better if you can. Use the maximum amount of oil that dish type will allow, and ensure you allow full time for equilibration. Monitoring individual performance with embryo transfer is crucial, both clinically and embryologist, and often combinations of the two, to ensure that we give the patients the best chance of success. If we've created beautiful embryos, we want a nice, easy transfer to give them the best chance of implanting and forming a healthy, normal pregnancy. And just to conclude, optimization without compromise, spectacular achievement is always preceded by unspectacular preparation. Doing the same thing right every time is critical and is a fundamental trait that embryologists should embrace. Sorry I ran over by a couple of minutes, but I really thank you for your attention, and I'm happy to answer any questions that you might have.
Thank you. Thank you, Dr. Levett, for a very comprehensive run through on how we should optimize embryo transfers and what is going on in the lab. It seems that there's a lot that we need to actually pay a lot of details and attention to. Well, there are a few questions from the audience. First and foremost, there is actually an audience that actually asks about satellite centers. So in the context of IVF clinics that utilize satellite centers for oocyte collection, followed by transportation to the main IVF clinics, which happens to some of the countries and some of parts of our Malaysian, clinics, because they're in the more remote areas. So they are asking, what are the recommended protocols, equipment and media and etc. to ensure the highest possible successful outcome? Well, I think that's a lot to do with temperature control, the environment control, and all the possible exposure to all the unseen environment outside the lab as well. So I think, Dr. Levett, I wonder whether you have any advice for them.
Yeah, well, I have some experience when we were in Canada. When I worked in Montreal, we did transport IVF by aeroplane. So from some of the very remote areas, they did egg collections and then shipped in a transport incubator the eggs to us. The sperm came separately, and we did mostly ICSI, but you can. So it can be effective. But as I mentioned, the key, and you mentioned as well, the key factor is control of the conditions while the material is in transit. So there are differences between eggs and sperm. So, of course, if you transport sperm in seminal plasma for any length of time, it's very likely that the sperm will be compromised. So that is a very difficult thing to do if you can't remove the sperm from the seminal plasma. As far as eggs are concerned, most of the transport incubators do not have CO2. They only control for temperature. So therefore, the eggs or the cumulus oocyte complexes need to be in a suitable medium that's going to only rely on temperature. So you can't use bicarbonate buffered media, so you can't use culture media or fertilization media. You have to use something like HEPES or MOPS. HEPES is better at 37 degrees to maintain a pH of around 7.3. MOPS works better at room temperature. So for transportation, I would use a HEPES buffered media, would ensure, and I've validated the incubator to be certain that the temperature remains very stable over that time period. Do a test run, make sure that the temperature in the fluid that's in the tube is at 37, because that's the key factor, and try, of course, to get it to your center as quickly as possible, because however hard you try, there will be some change over time.
Yeah, I think that's not the easiest thing to do, but I think that's the best that we can do.
Indeed,
Or
yeah.
yeah,
It's
in
not
both.
ideal, but it has to be done in some cases. And
Yeah.
if we do it, then we have to think about the environment and the consequences of change, particularly.
Right. We have another questions from the floor. What do you think about EMR and IVF witness in a IVF laboratory? Do you think that is very important? Because if IVF centers do not have EMR, it makes embryologists spend more time in checking all these things, identity and so forth.
Yeah.
Especially when there is when there are clinics that have a lot of patients. Yeah.
Yeah.
So that was the questions that from one of the audience.
Yeah, it's always a difficult question because introducing an electronic witnessing system, whatever it might be, has implications both for workflow, how we set the laboratory up, and not least of which costs. But there are some well-documented problems with doing manual witnessing. Manual witnessing, of course, is better than doing no witnessing at all. When I first went to Montreal from the UK, where we were one of the first countries to introduce compulsory witnessing, I went into the lab at Montreal when I first arrived and said, do you witness? And they looked at me as if I was slightly crazy. Of course we do. But they only witnessed the insemination. They didn't witness any of the other steps. We're going back to 2004. But they didn't witness any of the other.
That was not long ago. That was not that long ago.
It's 20 years ago. But so the mindset was, yes, we're saying that the sperm and the eggs that we're using are going together in the insemination phase. But of course, what happened before that? That's the key factor. Most of the errors that occur happen further downstream. So they prep the wrong sperm, it's mislabeled, etc. The problem with manual witnessing is that you get a number of factors that can come into play. You can get a busy lab where people are distracted. You get juniors witnessing seniors who think, oh, well, that's a senior embryologist. They must know what they're doing. So they call a name and they're not even coming to look at the dishes or the tubes, etc. So, of course, electronic witnessing can help in that regard because it never sleeps. It doesn't look away. It's not distracted. It doesn't know it knows the name, but it doesn't know how experienced the operator is. So it will always be there to help you. And when you look at some of the big data that's come out of clinics that do use electronic witnessing, the biggest one that has published data is now called IVF Brussels, used to be UZB. They have looked at the first 6,000 cycles that they did, and they identified that without electronic witnessing, there was a possibility that 7 clinically relevant mix-ups could have happened. So electronic witnessing, I think, protects you from a witnessing point of view. It can also help you in other factors in looking at your workflow, the use of certain equipment, how it's used, who does what, how long they take. It can help you with stock control. So it's certainly something to consider, but there are a lot of considerations before you do it. I think, personally, in 5-6 years or so, it will be a standard that all labs have to have. There's been resistance in the field, and we know recently in Israel, for example, a mix-up happened, and then the government said, right, that's it, everybody has to have electronic witnessing. It just happened in Qatar. So Qatar just brought in new regulations regulations for the first time, and the expert panel that put the regulations together, one of their criteria was you must have electronic witnessing in your lab. So some of the governments, some of the regulatory bodies are recognizing it. I think in time it will become a standard that everybody has to have.
Yeah, I think it is also very important in some of the population whereby the Asians are more homogeneous, and in fact they have a lot of similar names. And
Indeed.
you have the same Aisha, you have 10 Aisha, 20 Fatimas, and 20 Linglings,
Yes.
in the same day sometimes. And I
Yeah.
think mistake do happens if you have that kind of
Yeah, you're right. I
combination.
mean, it doesn't happen so much in the UK, but I remember one occasion where we had two patients, and one was called Young and one was called Youngs. So only an S on the end of the name. They had the same Christian name, same first name. And I lost sleep for several days while these two patients were going through, worrying that somehow we would mix them up because
Yeah.
it would have been so easy. So I don't want to lose sleep. I want to be able to go home on an evening. It's a hard enough job being an embryologist without dreaming about work as well. So I want to know that everything's protected. And I think witnessing and these electronic witnessing systems help you sleep well at night.
I think I absolutely agree that that's the way forward for all the labs in the world, if we can. All right.
If we can.
Yeah. Yeah. And there's another questions about off-gassing to get rid of VOC. How long do you advise to off-gas the dishes? And does prolonged off-gassing cause contamination to the dishes? Or do you advise to prepare media with laminar flow open? If so, how long is the preparation for dishes advised, as it may affect the osmolarity of the media? So these are a few questions
Yeah,
from the
sure.
attendees.
Yeah. And of course, plasticware is different. Depends which brand you buy, how the packaging is set up. There are some dishes that come in packs that are breathable. So they're off-gassing as they're being transported. Others are not. So we usually recommend 24 hours for off-gassing. And we usually, ideally, because I'm working in a virtual world, I try to say what is ideal, and then people have to adjust to what they can do. So ideally, when you're off-gassing, you don't do it in your main embryology lab. You have a laminar flow available somewhere else, but most labs, unfortunately, don't have that. So don't have the back of your workstation completely flooded with dishes. Just off-gas the ones that you think you're going to need within the next 24 hours and keep that as a rolling stock. There shouldn't be any contamination because you're going to off-gas them in your laminar flow, your class 2 cabinet, so it shouldn't be contaminated. From that paper and from my experience that Jason Swain published, it showed very little difference if you do one dish at a time when you're making dishes. This is the crucial factor. If you make one dish at a time, it made very little difference whether the laminar flow was on or off. So our recommendation is you always leave it on because you're trying to minimize contamination. I would always ask my embryologists to wear gloves when they're making dishes, but there are many that don't. So we think our hands are sterile, but we work in the lab, we touch things as we go along. So we can contaminate things, we can contaminate the air around us. So you should work with the airflow on, but you should only make one dish at a time. And if you do that and you get the oil on top of the drops quickly, then you're going to minimize the risk of evaporation. And don't use too small a drop. Because again, when I ask embryologists, they say, well, what sort of drop should we use? And I ask them, what size are you using now? And they say 10 microliters. And I say, why? What reason is there to use 10 microliters? And if you do group culture, there is this belief, and I'm not a real believer in this, that you get these paracrine and autocrine factors, and they're going to be more pronounced if the drops are smaller. But you've got to weigh up the benefit and the risk. And the risk of using small drops is they evaporate very quickly. And a professor in Belgium once asked me, he said, how many human embryos do you think will fit in 1 microliter of medium? So he'd done a calculation based on volume of the embryo. And it turns out 240 human embryos will fit in 1 microliter. So 10 microliters is already a huge excess for one embryo. So why not do more? Why not reduce your risk, reduce your stress, and use 30, 40, 50 microliters? So that's going to reduce your risks and get the oil on top of the drops as quickly as possible. Then you should be safe.
Right. Thank you. That saves clear a lot of doubts in many of us. Unfortunately, a lot of our lab do not have the space and the luxurious space to have a laminar flow
Outside. I know.
outside. Yeah, so
Yeah.
that poses a difficulty.
It
And
does, but that's why I say don't crowd, don't have
mm,
packets and packets and packets of dishes off gassing. Do it on a rotational basis. You have some that you're going to use, then replace them and do it that way. Don't have, because your work surfaces should be as clutter-free as possible. And ideally don't do it in a workstation that's going to be doing critical procedures. So certainly don't put dishes to off gas in the workstation where you tube biopsy samples, for example. So think about what you're doing in there and what's going to happen in there and try and choose a suitable location.
right, we have a clinician who asked about the fluid in the endometrial lining. Abandon if you can see fluid in the endometrial lining. What will be the measurement? What is the minimal measurement of so-called fluid? Because sometimes some patients do have some degree of fluid which might disappear after ovulation, for example, and why there can be a fluid endometrial lining. I'm sure that there are many reasons for that. Yeah, Dr. Levett, would you like?
There are many reasons, and the literature is really quite clear. And I guess it was always a lot more problematic 15 years ago, before vitrification came in. So when we did slow freezing, we were always concerned that the embryos that we froze would not be as viable as the ones that we were doing fresh. Nowadays, with vitrification, there is no doubt if your vitrification system works effectively, what you put in, you get out. So if it's a good embryo and you vitrify it correctly, you'll get a good embryo out. So when we don't know what the fluid is, it could be infection.
Hydrosalpinx.
It could be hydrosalpinx that's coming down. It could be endometriomas. It could be many, many things. It's just not worth taking the risk. So even if it's a vitrified embryo, you can re-vitrify if your system is robust. If it's a fresh embryo, there's no problem. So on a much more trivial level, embryologists ask me when they do use the syringe for embryo transfer, what do I do if it's sticky? Should I, manipulate it? And there's a simple answer. You throw it in the bin and you get another one. You don't want to risk what is the critical factor in IVF, the embryo transfer, for things that you can manage and avoid. So if I see fluid in the endometrial cavity, I'm going to think, wonder what it is. Is it going to disappear on the day of embryo transfer? If it doesn't, and I see it, I see no reason to risk doing an embryo transfer when you could postpone it. Try to find out what it is, see if the patient has hydrosalpinx, see if you can do an endometrial biopsy, do something to try and understand, and then put the embryo back in another cycle, in a frozen cycle.
Well, there seems to be a lot more questions coming through now. Then there is another questions about transvaginal guided embryo transfer. What is your experience on this, Dr. Levett?
I have to say a little bit limited. Have done it. I have done it with some clinicians. Of course, the beauty, as we know, of transvaginal ultrasound is that the image that you can get is so much better. So if you want to be extremely accurate in the placing of the embryo, it's actually beneficial to do transvaginal transfer. Technically, it's more difficult, as you know yourself. If you've got to hold a probe and you've got to insert the catheter underneath, but you can do it yourself.
Three arms.
You've got to have three. You've got to have three hands. You've got to hold the probe still as well. So once you know, and of course there are some issues with transabdominal scanning. It's often not easy. The image is not great if the patient's obese. If the person, so often I see when I'm doing an embryo transfer with a transabdominal probe, there's an ultrasonographer or a nurse holding the probe, but then the clinician's not happy. They reach and move the probe themselves. So again, you've got to be realistic. I think we don't have the best catheters to doing transvaginal transfers. We don't have the best setup yet, but if you can do it, of course it can be extremely effective. and the placement is much more accurate because the vision, the image that you see is much better.
Absolutely
Again,
agree with you.
we might see it in 5 years that when we have better equipment, better products for transvaginal transfer, it's still fairly niche. There aren't so many people doing it worldwide, from my experience at least.
We have another questions about KPI, Dr. Levett.
Okay.
There is actually questions about the oocyte being fragile during ICSI. Should it be included in the data when you calculate KPIs? Thank you. So I think that is actually about the percentage of
Yeah,
fertilization and all that. Yeah.
Yeah, I don't think necessarily it should be a KPI, but it's certainly something that embryologists should record.
Yeah.
So if I see anything during a cycle with a patient that's out of the norm, I make a note. And so if I feel no resistance for the injection pipette when I'm doing the ICSI, I make a note. And even if I get normal fertilization, I'm going to think about that egg, think about the quality, and think about which embryo I might want to transfer or vitrify. But this is information because there are a number of reasons why eggs can be fragile. It can be back to the stimulation regime. It can also be the way that the denudation is done. There are many, many factors. It can be just patient age, for example. So I don't see that you can measure it as a KPI, but it is something that you should record and you should discuss with the clinical team to see if there's anything that can be done subsequently to avoid it happening. You know, sometimes you get this discordant growth of the follicles, and we go with the leading follicles, and then there's a big group of smaller follicles that we sort of ignore a little bit. We might do that as our standard for the first cycle, but if that's not effective, we may ignore the leading follicles and go with the subsequent cohort. And that might be reflected in the type and the quality of the eggs that we see. So there should always be a dialogue almost all of the time between the embryology team and the clinical team where we discuss these things. They don't work as separate entities, because I always say to embryologists, it's important to feed back to your clinical team. We cannot make good embryos from poor quality eggs.
Absolutely.
Unfortunately, embryologists can make poor embryos from good eggs if they're not careful, but we need to have good starting material to help us do the best that we can.
Absolutely. What do you, and out of curiosity, there is a new device that was actually measuring the integrity of the wall of the oocyte, is that right? And looking at
There is,
pressure.
yeah. I mean, yes, and again, there's a lot of talk about robotic ICSI, automated ICSI. There's a talk about the current that passes through. So one of the things you need to be cautious of is that the sperm is actually deposited within the cytoplasm, that you're not just putting it outside into that funnel that forms. So you can test by an electric current the integrity of the oolemma. I've seen in some labs in Turkey particularly, where they call it Frankenstein ICSI. So they inject the eggs and then they put them into a special dish and they pass an electric current across them. It's possibly a mix of oocyte activation as well. If you aspirate the cytoplasm, in most cases, that's effective enough. But again, we'll see electronics, AI, machine learning, all of these new techniques will come. The true test is whether they are applicable on a daily basis. And of course, there's always this cost benefit. SpindleView fell into that group. SpindleView is a great tool for research, but it's incredibly expensive. And when you look at the outcomes, it doesn't, for most labs, make economic sense. It's a very expensive tool to have in your lab, and the number of patients that truly benefit from it is very limited. If budgets were unlimited, we could do all of these things, but we have to look at what's applicable and what's going to give us the best outcomes in our system, in our clinic, to give the patients the best chance of success.
There is another questions about maintaining temperature. It seems that you mentioned that the hand cannot retain the temperature of 37 degrees Celsius. What suggestion would you give in handling the follicle aspirated tubes?
My recommendation is that you don't hold the tube during the aspiration. So One of the problems that you see worldwide is when you're doing the egg collection, the clinician wants to see the flow of the fluid into the tube. And of course, you can only really do that if you're holding the tube. So the nurses don't even hold it in their hand. They're holding it close to the bung so you can see the flow of fluid. This is problematic. That is the greatest temperature loss during egg collection. So ideally, the tube sits the whole time in the tube warmer till it's full, and then you take it. Of course, you have to transport it in your hand, and you put it into a new tube warmer that the embryology has on their hatchway or in the lab itself. You can mitigate some of the issues by pre-loading the tubes with medium that's at 37 degrees. So if you put 2 mils of Heapes buffered media in the bottom of the tube, pre-warmed, again, that will mitigate some of the issues, but either holding it or certainly holding it by the bung is not going to maintain 37 degrees. There are some devices on the market, some tube warmers, that they have a jacket which has a slit cut in the side, so you can actually see the tube going, the fluid going into the tube. So you need to maintain it in a controlled environment as much as possible, and your hand is not a controlled environment. So holding the tube should be an absolute minimum to get the best results.
So there's a no for that. Yeah.
Ideally,
right.
yeah.
Yep. There is also another question about the volume of media in the catheter during embryo transfer. So they were asking, their attendees are asking, what is a recommended volume?
Yeah, so around 30 microliters. But again, what we don't want to happen is embryologists move up and down with the syringe. Oh, that's a bit too much. That's a bit too little. And time is of the essence. So for me, the way I've taught embryologists to do embryo transfer, when they're loading the column of medium, I say to them, as long as it's between 0.5 centimeters and 1 centimeter of the medium drop, then that's perfectly adequate. That's going to be around 20, 30 microliters. If you take up too much fluid, then you fill the cavity, you run the risk that the embryo will be pushed towards the tubes. If you use too little volume, that also seems to be detrimental. And there's a risk that the embryo will be retained close to the tip of the catheter. It really depends, a lot depends on the clinician that you're working with and what they want to feel when they press the plunger. So I've worked with some doctors who just want to feel a small push, and some want to feel a quite significant push on the plunger. If they want to feel a significant push, you add more air. Okay, you can add air. Air is not detrimental, but increasing the volume of the media is. So you want to be aiming for about 1 centimeter. If you look at the catheter as a tube of plastic, about 1 centimeter, if your embryo is within that, that's perfectly okay. There or thereabouts. You don't need to be exactly accurate, because that will take time if you want to measure an exact amount. So as long as it's in that range, and again, I mentioned, once you've pushed the plunger, you should keep the pressure on it, because once you release the pressure on any syringe, it causes a little bit of reverse pressure, and it can draw the embryo back towards the catheter. So always keep the pressure on and then remove the catheter.
Well, there's some other questions about, speculum. Why is that there's no need to pre-warm the speculum before embryo transfer? Wouldn't the warm speculum reduce patients' stress by preventing discomfort from the cold, given the temperature in the operating theater?
Yeah, I think probably like the speculum itself, the recommendation probably came from men who have never had to have a speculum in their body ever. So what the research says, it doesn't make any difference in outcome, but in comfort, of course. I mean, it's I'm a big believer that we should use disposable speculum. We should never use the metal ones that are reused. It's just awful.
It's awful. It
When you
really
see
is
them
awful.
come back from SSSD, they've got flakes of blood. Anyway, we don't need to go into that. I would always recommend using a disposable speculum. They're usually made of plastic. My understanding is that it's not as cold as a metal speculum. But again, there's no reason if using sterile water not to warm it if you choose, if you have the setup to allow that. And as you say, for comfort, and we mentioned patient comfort is one of those things we should always be trying to achieve. But in terms of when you look at the data, whether it makes a difference to outcome, it actually doesn't. So whether you do or you don't, but again, probably guidelines written by men, not women.
There is actually another question about egg collection. Whether do you prefer a single lumen or double lumen catheter during needle,
Yes.
during egg collection?
What a great question. The published data tells you that only one exception does flushing make any difference, and that's in natural cycle IVF. So if you do poor responders, normal responders, hyper responders, flushing makes no difference. Does that mean
egg
it's
number
not,
of eggs retrieved?
so you have to, this is where we have to be careful in usable eggs retrieved.
Right.
So you do get more eggs, but you get GVs, you get M1s, you get necrotic eggs. So you end up with a greater cohort of eggs, but you generally don't end up with more embryos because you're going to recover the eggs which are really not viable. So in terms of, I say, all of the published data, it's recommended that you don't flush. Will doctors ever stop flushing? I suspect not, because we're human beings as well. We're not just scientists. We're not just read the literature. We want to do the best for our patients.
Absolutely.
And we also know nowadays that patients are much more informed. So a patient will come to you and say, but doctor, I had 3 follicles. Why did I only get 1 egg? So it doesn't matter to them that they got 1 normal egg, 1 necrotic egg, and 1 GV. They've then got 3 eggs. So they think, so it's all about psychology. It's all about being human.
Expectation.
And manage expectations. Perfectly put. But in terms of, if you look at the data and the published data, it really doesn't make any difference in most cases. If you don't flush, of course, the egg collections are quicker. And they're also less expensive because dual lumen needles cost more and flushing media costs more. Now, a lot of distributors don't want me to say that because if they sell flushing media, they sell dual lumen needles. But I only talk about what the data says, and the data says it doesn't make any difference, except in natural cycle IVF, where there is some evidence that flushing is beneficial.
And what about the pressure that you use to aspirate the eggs?
So pressure is a little bit of a misnomer. It doesn't matter what the pressure is to an extent. So what we need to work out with the needles is flow rate, and we adjust the pressure to get the correct flow rate. So as long as the pressure is not above, say, 100 millimeters of mercury, which would suggest there's some issue with the system. So we're going to be in the range of 80 to 180 negative millimeters of mercury. What we're looking for is a flow of about 25 milliliters per minute. So when you're setting your system up, you put your needle in a tube that has media or water in, you press the foot pedal, you measure the flow into another tube, and you need to work so that that is around 25 milliliters per minute. Every needle has different gauges, different tubing. So there is not one setting for pressure. It's all about flow rate. And if you get the flow rate right, it'll minimize any risk of damage. But we need to adjust the pressure to get the flow rate. So flow rate is our focus. Pressure gives us that flow rate. And as I say, it'll be different from every different type of needle, different lengths of tubing, etc. But the key is, as long as it's below, say, 200 or 180 millimeters of mercury, you're okay. If you're having to pull the pressure really high, then something's wrong in the system. So you then need to investigate further.
Okay, in the interest of time, I'm just going to ask you the last question.
Okay.
This attendee says that his clinic has got very high ectopic pregnancy rate. And how do they fix this problem?
Oh gosh, how long have we got? I mean, I would look at embryo transfer. I mean, the the ectopic pregnancy rate reported in IVF is somewhere around 1 to 2%. So of course it can happen, even if you put the embryo in mid-cavity, you can still, so you need to look at the patients that are having ectopic pregnancies. Have they had surgery? Have they had the tubes removed, etc., etc. So you can still get problems at the junction between the uterus and where the tube would be, even if they have not had the tube removed. Have they had surgery? But I would be looking at the embryo transfer, where the catheter is being placed, where the embryo therefore is being deposited, and the volume that you're using. If you're using a very high volume, it can force the embryo towards the tubes and cause a problem. But as I say, we know, unfortunately, there are always cases of ectopic pregnancy. But if it's more than 1 or 2%, then something is wrong, and you need to look at your processes, embryo transfer particularly, because that is the most likely cause, if it's not patient related.
Right. So I'm going to thank Dr. Levett for this very interesting talk, and thank you so much for such informative lectures on various areas in in optimizing our outcome in IVF. Now, for the audience, please do remember to do the post-webinar survey at the end, so that we can know what we can do to make this webinar better for future references as well. So thank you very much, Dr. Levett, for a very interesting talk. We hope to see you again soon. My
pleasure, and I hope so. I hope I can meet some of the audience actually in Malaysia at some point. My brother used to work in Malaysia, so I spent a little bit of time with him in Kuala Lumpur. So I look forward to visiting some point in the future. That'd be really nice. Or see some of you at ESHRA or ASRM or wherever it might be.
Yes, we'll be there. All right. Yeah. See you soon.
Stay safe, stay healthy. Yeah. And thank you so much. Thank you for inviting me.
Good night. Have a good evening.
Yeah. Night. Bye.